Hello, sir. Can you hear me? Hello, hello. हेलो। हेलो।
हाँ बोलिए।
सर मेरी आवाज़ आ रही है ना आपको?
हाँ 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 ठीक है।
ओके।
एक्चुअली आई एम यूजिंग टू कनेक्शन।
ओके।
ठीक है, एक्चुअली लैपटॉप का साउंड थोड़ा कम है, इसलिए मैं मोबाइल का साउंड यूज कर रहा हूँ।
ठीक है चलेगा, बट आप एक को म्यूट रखना, नहीं तो वो इको
हाँ,
आएगा।
मैं लैपटॉप म्यूट कर दिया।
हाँ हाँ चलेगा, ओके।
ओके। কান্তন দা, গুড ইভিনিং।
Good evening.
ভালো আছেন
Just
তো?
system check.
হ্যাঁ হ্যাঁ হ্যাঁ, ঠিক আছে ঠিক আছে। ইউ আর অডিবল অ্যান্ড ভিজিবল অলসো।
Oh, fine. Slide presentation তো কিছু নেই, ফলে
না না না
স্লাইডের
না,
কিছু
স্লাইড কিছু থাকবে না। ওই মডারেটর ডক্টর পিকে কুন্ডু থাকবেন, উনি ওই কিছু
হুম,
স্পেসিফিক পয়েন্টের উপর কথা বলবেন।
হ্যাঁ জানি, সেটা তো অলরেডি শেয়ার করা আছে।
হ্যাঁ হ্যাঁ
তো
হ্যাঁ,
তাহলে আমরা কি করব, আমি তাহলে 8:30 লগ ইন
একদম
করা থাক, 8:30 আমি
ভিডিও অন করুন।
জয়েন করে যাচ্ছি।
হ্যাঁ হ্যাঁ হ্যাঁ, ঠিক আছে স্যার।
ঠিক আছে, ওকে।
Sir, good evening.
Good evening. Can you hear me?
Yes, sir. Yes, sir. You are audible, visible both.
Okay, clearly.
Yes, sir. Clearly.
Okay. Other panelists have joined.
Sir, Dr. Sayantanu Rai already checked his attendance, and other will joining soon.
Okay. Because can you start it sharp at 8:30?
Yeah. Sure, sir.
Because it's Sunday night, you see.
Yes. এমনি যা করোনা আসছে স্যার এখন এভরিডেই সানডে হয়ে যাওয়ার মতো অবস্থা হয়ে যাচ্ছে আর কি।
হয়ে যাবে আলটিমেটলি। হ্যাঁ, এভরিডে সানডে হয়ে যাবে। Each and every house is affected with all the members.
Yes, sir. আবার মনে হয় স্কুলগুলো ভ্যাকেন্ট করে আবার হসপিটাল বানাতে হবে।
হ্যাঁ, করছে তো। হয়তো আজকে কোর গ্রুপের মিটিং ছিল, ও তো বেড এক্সটেনশন করছে।
ওই ইলেকশনের জন্য আর একটা স্কুল কিছু নেওয়া আছে।
হ্যাঁ, এমনি যেগুলো পারবে বা যেগুলো টেন্ট বা স্টেডিয়ামে যেমন টেন্ট খাটিয়ে হয়েছিল ওই একই রকম এটা অ্যারেঞ্জমেন্ট করতে হবে।
Good evening, sir.
Good evening. How are you?
Going fine till now.
Okay, looking fresh.
স্যার আপনার সঙ্গে ওই 2019-এর নভেম্বরের ওই সায়েন্স সিটির প্রোগ্রামটায় দেখা হয়েছিল।
তারপর তো সবই ভার্চুয়াল হয়ে গেল।
হ্যাঁ, তারপর তো আমরা মানে তার ঠিক মানে জাস্ট 2020 শুরু হলো, সবকিছুই
2020 হয়ে গেল।
হ্যাঁ,
এখন আবার 2021ও হয়ে গেল।
হ্যাঁ, এরপরে তাই ক্রিকেটও তাই শুরু হবে, আইপিএলও।
আইপিএল এর খেলা তো চলছে, দর্শক শূন্য স্টেডিয়ামে খেলা হচ্ছে। আর এদিকে আমাদের ওয়েস্ট বেঙ্গলে
ভোটেরও খেলা চলছে।
ফলে আমাদের অবস্থা খুব সঙ্গীন আর কি।
ঠিক।
গৌরব জয়েন করেনি এখনো না?
গৌরব দা মিনিট 10-15 আগে হসপিটাল থেকে বেরিয়েছেন, তিনি বললেন যে ওই আর 10-15 মিনিটের মধ্যে ঢুকছি।
আচ্ছা, আরো তো দুজন আছেন বোধহয় প্যানেলিস্ট।
হ্যাঁ, ডক্টর অগ্নিমিত্র ভট্টাচার্য আর ডক্টর মনোজিৎ কুমার।
হ্যাঁ, সবাই না এলে তো স্টার্ট করা যাবে না।
না, আমরা আরো একজন দুজন এলে আরম্ভ করে দেবো, ইন দ্য মিন টাইম আরো লোকজন ঢুকে যাবে না।
না, প্যানেলিস্ট সবাইকে তো আসতেই হবে।
স্যার ও ডিসকাউন্ট মানে ডিসকাশন করতে করতে বাকিরাও ঢুকে যান আর কি।
ঠিক আছে।
That Melissa,
কুন্ডু স্যার, ডক্টর ভট্টাচার্যও জয়েন করে গেছেন, তো let me start, and in the meantime Dr. Bhaduri will join. অগ্নিমিত্র দা, গুড ইভিনিং। সায়ন্তন দার মনে হয় একটু সাউন্ডের ডিস্টারবেন্স আসছে,
সাউন্ড
একটু আওয়াজ আসছে, খুব ফ্যানের আওয়াজ আসছে মনে হচ্ছে।
করে আবার আপনি করতে পারো।
এবার ঠিক আছে। নেটকাস্ট চেতন রেডি?
Yes, sir.
কুন্ডু স্যার, can we start?
Yes, yes, you can start now.
Yeah. So, very good evening to all doctors. Let me welcome all of you in Alkem Digital Platform. Alkem is the 5th largest pharmaceutical house in India. Today we virtually assemble over here to share, to discuss galaxy of experience with rosuvastatin. Now I would like to welcome Dr. P.K. Kundu sir as a moderator in today's webinar. Dr. Kundu, having rich experience in endocrine, nutrition as well as metabolic disease. Earlier, he was attached with School of Tropical Medicine, Kolkata. So, welcome Dr. Kundu sir. And let me welcome Dr. Sayantan Rai. He is an endocrinologist. So, welcome Dr. Sayantan Rai. And let me introduce Dr. Ognimitra Bhattacharya. He is an consultant physician. So, welcome Dr. Ognimitra sir. So, now I hand over Dr. P.K. Kundu sir, and in the meantime, other two panelists also will join. So, hand over to Kundu sir.
Good evening, everybody, and all the panelists, Dr. Manjit Kumar, Dr. Ognimitra Bhattacharya, and Dr. Sayantan Rai, and Dr. Gaurav Bhaduri will join sometimes later. And also good evening to all the members of the Alkem family and all the members of the technical support for this today's virtual panel discussion on the management of dyslipidemia in the different clinical situations with and comorbidities. Now, before going to the panel discussion, I just express that there are practically many guidelines across the world. Guideline A, guideline on the diabetic and hypertension, or the British guideline, European guideline, ESC guideline, and NICE guideline, Asian guidelines. So all these guidelines are somewhat confusing. So from this panel discussion, we try to emerge what will be practically the following guidelines. We have to practice in your clinical subjects in our clinical practice so that we can achieve the best effort in the management of the cardiovascular disease, especially the atherosclerotic cardiovascular disease, and also the onset and the events, and also the cardiovascular mortality and morbidity to be reduced by the management of dyslipidemia. So before going to the panel discussion, I will also ask the panelists that what will be their approach, whether they are approaching for the LDL cholesterol goal or for the non-HDL cholesterol goal. So I ask Dr. Sayantan Rai, because he has joined first, and please tell your vision that what you have been approaching for the management of the dyslipidemia, for the targeting the LDL cholesterol or the non-HDL cholesterol.
Usually, in the management of dyslipidemia, as also recommended by most of the cholesterol guidelines, that we should first target LDL cholesterol, because LDL cholesterol lowering has a direct relationship with reduction of atherosclerotic cardiovascular disease. So in my practice also, I follow that principle that I first target the LDL goal.
Yes, practically all the trials which have been taken across the world, whether that is the RCTs or the observational studies, that have shown only targeting the LDL cholesterol and very few studies on the HDL cholesterol. And it has been found that if we targeting for the LDL cholesterol, the better correlation with the cardiovascular outcome has been obtained with the study. So till LDL cholesterol is the target goal for the management of dyslipidemia. Now I go to other panelists that before going to the discussion, we have to know that what do you mean by the high intensity statin therapy, medium intensity, and the low intensity statin therapy.
Yes.
Please clarify it first, and then we go to the actual discussion.
For high intensity statin, it depends on the which statin. As we are discussing on rosuvastatin in this panel. So in case of rosuvastatin, if we use 20 to 40 milligram, this is high intensity statin.
Sorry, I interrupt. Because we do not go for only the rosuvastatin today. We actually include all the statins, whatever you feel, because we have also to see that how the rosuvastatin and atorvastatin scores in the different situations. So it is not only on the rosuvastatin, also we go for the other statins also.
The high intensity statin we are using in patients with higher ASCVD risks. For example, in diabetics, in where the risk is more than 7.5%, in that population, we are using high intensity statin, where the statin dose is higher.
But probably I think Sir is asking the what is the definition of high intensity statin therapy or moderate intensity
and low intensity statin therapy.
Sir, if with high intensity statin, we mean that with the daily dose of that statin, you expect more than 50% lowering of the baseline LDL cholesterol. And for moderate intensity, with the daily dose of that statin, we expect a 30 to 49% reduction of the baseline LDL cholesterol. But dose is different, 20 to 40, what Dr. Bhattacharya has mentioned for rosuvastatin is a high intensity dose considered. And for atorvastatin, that is 40 to 80 milligrams.
Yes, and low intensity is the lowering of the LDL target cholesterol below 30% of the baseline.
Yes.
And that is between 10 to 20 milligram of atorvastatin and 5 to 10 milligram of rosuvastatin.
Yes.
Now, I have to, in my mind, that what will be the initiation of the statin therapy or the accentuation of the statin therapy in the settings of ACS, acute coronary syndrome. What will be your target goal? And what statin you have been using in the setting of ACS? Actually, what we have going for the treatment of the ACS, we have been actually using the atorvastatin at the dose of 80 milligram. Because the trials actually with the atorvastatin, but we do not know that why rosuvastatin has not been trialed so much for the in the treatment of ACS. Because actually in ACS, we have only not to decrease the LDL cholesterol level, but also we decrease the arterial inflammation. That means the vascular endothelial inflammation. And so 80 milligram atorvastatin has been started. And how long it will be continued? And it will be continued for at least 3 months.
3 months.
Intensity statin therapy. And after that, if the maximum tolerated statin dose has been obtained, then we can change over to rosuvastatin after 3 months to 40 milligram. And then it will be continued for 6 months. And after 6 months, the routine practice is that we have to actually continue with the 20 milligram to 10 milligram rosuvastatin as per the tolerability of the statin dose. Now, on that perspective, say the post angioplasty patient or post CABG patient, we have also practically followed the same protocol. That means the high intensity statin therapy, a 40 milligram rosuvastatin or 80 milligram atorvastatin for 6 months, and after that it will be reduced to 20 milligram rosuvastatin or 40 milligram atorvastatin, and it will be continued for another 6 months. And then as per the LDL cholesterol goal level which has been attained, we have to reduce the dose as per the tolerability of the statin. Now I ask the panelists that what will be the practically role of the statin in the background of diabetes mellitus, because we know that type 2 diabetes mellitus or the type 1 diabetes mellitus, when they have actually reached their adulthood, because you know that insulin therapy will increase the lifespan of the type 1 diabetes, and they have been suffering from the dyslipidemia. And this dyslipidemia and the diabetes, actually type 2 diabetes, the major cause of death is the cardiovascular death, because the cardiovascular events like that of myocardial infarction or acute coronary syndrome or failure with the hospitalization, or there are the sudden cardiac death, all have been increased in the background of type 2 diabetes. And so I think that in type 2 diabetes, practically there is no primary prevention, because everything is like that of secondary prevention. Because what we have seen in our clinical practice, that the ASCVD practically is present in almost all of the type 2 diabetic subjects in the middle-aged or the elderly age group, because and sometimes the ASCVD is clinically not significant, but if you go for the lab investigation, you can reveal the presence of the ASCVD at least, and in the tune of the 50 to 80% presence of the ASCVD in all of your type 2 diabetic subjects. So what is your role of approaching for the statin therapy in this acute ASCVD in the background type 2 diabetes? So, Shantan, please.
Sir, should I share my view?
Yes, yes.
Now, for patients with type 2 diabetes, in day-to-day clinical practice, again, the problem is that who don't have clinically apparent or a history of prior cardiovascular event, in terms of statin use, again, the context is for primary prevention of cardiovascular disease. But those who have already an event, there is no question that whether we will use statin or not. But those who are not having any prior cardiovascular event or clinically apparent atherosclerotic cardiovascular disease, here comes the question that should we put all diabetic patients who are aged above 40 years on statin or not? So that comes the question whether we should use for the primary prevention of cardiovascular disease in patients with type 2 diabetes who do not have any prior atherosclerotic cardiovascular disease or events. Here my take is, as per the current knowledge and data, probably using a moderate intensity statin to all type 2 diabetes patients who are aged above 40 years would be beneficial. And probably the harm here is very small with the moderate intensity statin. And that's why I feel it's appropriate to put type 2 diabetes patients who are aged 40 years or above, at least moderate intensity. For high intensity, we have to again risk stratify whether there is any additional cardiovascular risk factors in there, or if the 10-year ASCVD risk is more than 20%, so then probably high intensity would be a better choice. But having said that, as we increase the intensity of statin therapy, it becomes costlier, need frequent monitoring, and also compliance issue is there because many patients comment that আমার তো লিপিড প্রোফাইলটা নরমাল আছে, আমি কেন স্ট্যাটিন নিয়ে যাব। means we need to justify also the intake of a daily medicine when in the context of primary prevention.
I have a comment to make, sir, if I can, please.
Yes, you can continue.
Yeah, so I also strongly support what Dr. Shantanu Roy said, that statins are very important for those patients who are aged above 40 and having also diabetes in those patients. So ideally, as per the current evidence, it is slightly in favor of starting patients who are aged more than 40 years and having also diabetes. Now, in those group of patients who have diabetes, now they can be risk stratified in 3 different categories. One is having a ASCVD along with diabetes. Another is having only diabetes and having no other, high risk factors like hypertension, smoking, chronic kidney disease, at least stage 3 and 4, or a family history of a premature coronary disease. So if patients are not having any of these factors, so they are having only type 2 diabetes, then they will fall in another category. And there will be those patients who have diabetes plus additional 1 risk factor. So this is the way that actually AAC has classified the LDL target goals. And I think it becomes a little easier for practicing physicians to have a goal. Because ACC and AHA, they haven't really specified a goal management. They have mostly dictated on the base of the intensity of statin, the degree of LDL reduction. But ACC is very specific on the target LDL goals. So if a patient is only having diabetes, then the target should be less than 100. If the patient is having diabetes plus any one of the other high-risk cardiovascular risk factors, so then the target would be less than 70. And if the patient is having diabetes plus any of the ASCVD or established cardiovascular disease, then the patient target would be less than 55. So usually attaining a target of less than 55 would indirectly mean using a high intensity statin, because it's very difficult for moderate intensity statin to reach that LDL goal. To reach a goal of less than 100 for patients who have only diabetes, usually a moderate intensity statin is good enough until and unless the LDL is by far very high in the range of 180, 190 or more than that. So in the middle group, in those patients who have diabetes plus one of the cardiovascular risk factors like smoking, hypertension, chronic kidney disease, stage 3, 4. In those subset of patients, I usually start with a moderate intensity statin, see the tolerability of the patient, and try to escalate the dose of statin according to how the patient is responding to that particular dose. And if they are not reaching the goal of less than 70 with a moderate intensity statin, then we can go ahead and up titrate the statin. Or if the patient is not tolerating a higher dose, maybe we can add a ezetimibe to lower the LDL target.
Subject has no evident atherosclerotic cardiovascular disease, but see that his ankle brachial index is less than 0.9, or the CRP is above 2, or the subject has the prior history, or the subject has the poor family history, like that mature cardiovascular death in the family, or a subject going for the CT angio can show that coronary calcium score is above 300. Then how do you manage this subject, whether with the high intensity statin therapy or the moderate intensity statin?
So my take on this would be based on the AAC guidelines. The LDL level should be at least less than 70 in this group of patients. So with diabetes and one additional risk factor. So it can be a traditional risk factor or the modern risk factors that we are now evaluating. So for this patient, the target LDL should be less than 70. So it is better, for my opinion, better to start with a moderate intensity statin and see whether we can achieve this goal. If not, then we can go ahead and increase the dose and try for a higher intensity statin, provide the patient is tolerating it. Because in Asian patients, in Indian patients, statin tolerability is definitely an issue. And it has been recorded in different trials that Asians do not tolerate statins as well as Caucasians do.
So one point to make here, if we see that most patients who are aged between 40 to 75 years and having diabetes are already at intermediate or high risk. If we use a pooled cohort equation, it will be more than 7.5%. So giving statin in this age group, the evidence is strong. Another point is that this age group is actually represented in the statin trials. That's why we have a weaker evidence below 40 and above 75 years.
Right.
That's why all in bracket 40
Yes.
to
75 is written, yes.
75 years. But what I feel in clinical practice, many a times LDL comes below 100. Sometimes baseline LDL even below 70. So in these patients, putting on a daily medicine is very difficult, and also the compliance issue. They will not take if you do not have enough justification for taking a daily medicine, which is not very low cost. That's why I feel all our diabetes patients are not identically at high risk. What I feel, we need more clarification on the risk stratification of the patients, that who are actually will get the benefit if we start statin in this particular age group in primary prevention setting, those who do not have already a event.
What I do, Shantanda, what I do usually is I tell my patients that I am prescribing you statin, though your LDL profile is absolutely normal, because it is not only the quantitative LDL assessment, it is also the quality of LDL. So you have got inside, because you have diabetes, you will inside your LDL is more atherogenic, and it is more likely to predispose you to atherosclerotic cardiovascular disease. So because they are densely packed LDL, okay?
Yes, small dense LDL.
Yes, small dense LDL.
That is very important. That
So
justification
counseling helped me. Yes, so this counseling has really helped me in my practice. And I can very much assure you that 99% of the times when I prescribe a statin, after listening to this, 99% of my patients is actually continuing the statin. But this one single line, that this is not only a quantitative assay, it is also about the quality of the LDL, which is not
Exactly.
represented here in the
Exactly.
numbers.
Yeah, that is
Yes.
very important to
Yes, that's okay.
discuss with patient.
Indians practically are more responsive to statin therapy. And even at the low dose, you see that the LDL cholesterol goal has been achieved between 75 to 100. So I
Yes.
think that the maximum tolerated dose which the subject can tolerate, that can be continued between the age 40 to 75 years in your type 2 diabetic subject. Because why we have not been extending the benefit of statin if the subject can afford it for the prevention of the any cardiovascular event for that particular subject or the advancement of the atherosclerotic diseases. So that's very important because statins have also shown that there may be the regression of the atherosclerotic patch. So that's very important, and they also reduce the thrombotic lesions. So the statin benefit should be given all the type diabetic subjects between 40 to 75 years. But after the age of 75 years, if there is the new onset type 2 diabetes and the subject has the LDL cholesterol, say 130 milligram, whether we can initiate statin or not in this subject. Dr. Ujjwala Bhattacharya, please.
Sir, in these patients above start with any high intensity statin because the tolerability I think will be very poor. But as you said, the LDL level is 130. We can start moderate intensity.
The trials have shown that in the elderly subject above the age of 75 years, the lowering of the LDL cholesterol by statin are much more benefited to prevent the onset of the atherosclerotic cardiovascular events than that of the younger age. So the those moderate intensity statin we have likely and whether that has been tolerated by the subject, it can be continued. But if it is not tolerated, then down titrate the dose of the statin. And Dr. Shantandai, please tell me that what will be the follow-up in your subjects after initiation of the statin? Whether you have been routinely checking the lipid profile at regular interval or the other liver enzyme tests like that. What is your opinion?
Usually, before starting statin therapy, usually I go for a baseline liver enzymes, and usually I repeat the liver enzymes, and after starting the statin, the next lipid profile I usually advise after 2 to 3 months. And if after 3 months the goal is achieved, then patient is continued on that dose which I have initiated, and I advise for a yearly follow-up with lipid profile. But if compliance is ensured, even if you cannot, you can avoid repeating lipid profile even annually also. But if compliance issue is there and you are suspecting that patient is not taking statin regularly, then probably an annual lipid profile would be of some help in that respect.
In our country, we have seen that there is practically the onset of type 2 diabetes 1 or 2 decades earlier than the white population. So we see many of our type 2 diabetic subjects in the younger age group. And
Yes.
say that if the subject in the younger age group, say between the age 20 to 40 years, and
Below
the
40, below 40.
onset of below 40, 20 to 40 years, and say there is the onset of type 2 diabetes, and the subject has the bad lipid profile, then whether you can initiate statin in these subjects.
Yes,
From the lifestyle.
yes,
Yeah,
we can
so-
initiate. Gaurav,
Yes.
please.
Yeah, so here the thing is that if the LDL is more than 190, so there is definitive indication of starting of statin therapy. But the issue is that if the LDL is between 100 and 90, provided that the patient does not have any comorbidities, so then there is certainly not very strong evidence that we have to start statin upfront in this patient population. So because how much protection we will be actually able to give this group of patient by use of statin is a little bit unknown. We don't know about this. But if the patient is having any of the complications like even a microalbuminuria, okay, or there is a reduction in the ABI, or there is a retinopathy that the patient has developed, because I just saw a few days back a patient with severe NPDR at the age of 38. So this patient actually developed a type 2 diabetes at the age of 25, and he was uncontrolled. As now 38, he has developed it. So this group of patients, if there is any of the complications that is there, which puts the patient at an indirect, very increased independent risk factor for cardiovascular disease. So these patients, even if their LDL is within 190, must be initiated on statin. Regarding the other group, where there is no such complications, even on extensive searching, and still the LDL is above 100, 130, or even 140, 150. There is this is a gray area, and not much evidence is there to support the use of statin.
And also a history of smoking.
Yes, smoking.
That
Yes.
is.
Yes.
And
Yes. Yes.
lifestyle therapy will be intensified in all the subjects. And you see, hello, can you hear me?
Yeah.
Yes, sir.
Yes, sir.
And if you see that the young subjects have type 2 diabetes onset and high LDL cholesterol, it is better to keep it between 75 to 100 with the minimum statin dose, which can actually reduce the cholesterol, because in the young subject, the lifestyle therapy will reduce the LDL cholesterol even up to the tune of 30 to 50 milligram. So the added to lifestyle therapy, even the low dose statin therapy can be helpful to minimize the progression of the atherosclerotic vascular disease in the younger subject. Now, what we have seen also in our younger subjects, that there is the onset of the metabolic syndrome. And you see that many of our female counterparts have the metabolic syndrome in the young age, though the metabolic syndrome has been associated with the high triglyceride and low HDL cholesterol level. But sometimes we have also seen that there is also the high LDL cholesterol level. But this female counterpart also in the reproductive age group, and they plan to sometimes conceive. Then what will be your opinion of the initiation of the statin therapy if in this reproductive age group, the young metabolic syndrome subject actually wants to conceive?
Sir, this is a very important area, but actually the problem is that still statin is considered, means contraindicated in pregnancy.
Category X.
And it is advisable that you should stop all lipid lowering medications at least 3 months prior to planning pregnancy. That's why it's a very difficult situation if during pregnancy, since many of the reproductive age women are having metabolic disturbances and the prevalence is increasing. So there is any situation that your patients who is on actually statin for management of dyslipidemia, planning to conceive, or even if in our country especially, many unplanned pregnancies happen. And that's why the statin safety in pregnancy, especially in the first trimester, has not yet been established clearly. That's why still the recommendation is statin is contraindicated. But if during pregnancy, severe form of dyslipidemias like very severe hypertriglyceridemia, or the patients who are having heterozygous familial hypercholesterolemia, they can present with severe elevations of LDL. So in that situation, probably we have to go for other measures than starting a statin, or maybe for triglyceride, maybe fenofibrate. It's difficult.
Practically, any woman plan to conceive, yes, you have to stop the statin therapy or should not initiate statin therapy at least 3 months before conceive, and throughout the pregnancy it is contraindicated.
Contraindicated.
And also during the lactation, it should not be used. So there will be barely a period of say 1.5 years like that, and at that period it should be stopped. And if there is a severe dyslipidemia, then you have to also search for the secondary causes, and that should be treated because it may not be the primary situation in that particular subject. Now we have been practically discussed about the use of statin in the diabetic situation, but what will be your choice in the non-diabetic situation? Say the middle-aged subject as the moderate atherosclerotic cardiovascular risk, and the LDL cholesterol say 160 milligram per DL. Then what will be your approach for the statin therapy, and how much you can actually permit the that statin can even induce the new onset type 2 diabetes? Then what will be your approach? Anyone of
make
the answer? Acha, where is Dr. Manjit
we will
Kumar?
start
Dr. Manjit Kumar is there?
No, sir.
Has he joined? I think he has not joined.
Okay, then anyone can give the answer.
Shantanda, tumi dao.
we will start with moderate intensity.
Means, sir, your question is for a new onset type 2 diabetes?
No, non-diabetic, middle-aged, LDL cholesterol 160, and then the subject is at risk to develop type 2 diabetes, and you have to initiate
Now,
statin.
if the patient is having a risk of developing type 2 diabetes, then another concern comes, the statin's diabetogenicity. So, means the risk of incident diabetes with the use of statin.
Yes.
So, preferably, if we agree to start a statin, preferably here a low intensity or less potent statin would be a better choice than a high intensity statin or a more potent statin. You may say that rosuvastatin or atorvastatin. I would prefer in a pre-diabetes patient pitavastatin, probably. And again, who is a middle-aged having a LDL cholesterol of 160, first of all, I will go for a risk calculation for the atherosclerotic cardiovascular disease for that particular patient. And if the risk is high, then we should put him or her on statin. But again, cessation of smoking, maintaining a healthy weight, that should also be emphasized, because statins are not a substitute for smoking cessation or treating hypertension or maintaining a healthy lifestyle. So that should be emphasized. But on the top of that, if clinicians think that this particular patient would get benefit if we put him or her on a low or moderate intensity statin, provided the risk of incident diabetes also taken care of, especially who is having pre-diabetes or having some degree of dysglycemia.
Yes, and also cut down the excessive carbohydrate in the diet. That should be also discussed with the subject to cut down the excessive carbohydrate intake. Because we Indians have seen in the different studies, even in START study, that we have been taking the carbohydrate portion between 60
START study.
So excess carbohydrate should be cut down. Say that LDL cholesterol, there is also the high triglyceride level. Then say the triglyceride level is between say 250 to say 400. Then how do you approach for that particular subject? And which statin preferred for lowering the triglyceride more than the others?
Yeah, so regarding statin, the main focus is always on the LDL. But yes, definitely there is around 15% reduction of triglycerides also. And rosuvastatin is obviously more potent in the reduction of triglycerides
Exactly.
in dose-to-dose comparison. Now, regarding the targeted, are we really targeting triglycerides over here, or it is the LDL we are targeting and we are getting a supplemental benefit on the triglycerides with use of a statin here? It is, we are not targeting the triglycerides here, because triglyceride lowering is whether it actually benefits, we still don't know, because we have tried that with fenofibrate and we have seen that there is no evidence that lowering of triglycerides actually help in reducing the cardiac events in this group of patients. When we are using fenofibrate to lower the triglycerides, when the triglycerides are at least more than 500, that also to reduce the risk of pancreatitis and not of kidney disease. So our target should be LDL whenever we are using the statins.
Another issue of the use of the fenofibrate is that there is a decline of the eGFR. And in the field study, it has been shown that there is a decline of the eGFR by 2 ml per minute annually. So
Yes.
with the use of the fenofibrate, there is the problem of damaging the kidney. And also, if you combine the fenofibrate with the statin, there are the more
Risk of myopathy.
Rhabdomyolysis, yes.
muscle
But
injury.
sir, I think the renal part with fenofibrate is reversible. Means when we stop the fenofibrate, then the decline in renal function or rise in serum creatinine probably comes to the baseline. And regarding triglyceride, until the results of the omega-3 fatty acids, we usually don't
Yes.
give enough importance to triglyceride, frankly
Right.
speaking.
Right.
And unless it is what Gaurav has rightly pointed out, if it is 500 or above, or some patients with familial hypertriglyceridemia having very high triglyceride to avoid the risk of pancreatitis. And nowadays we have also saroglitazar, which is a very potent, I think, in reducing the triglyceride quickly.
Yes.
So often we use that also in diabetes patient as well. But the studies with omega-3 fatty acid have changed some, again, the focus towards triglycerides, that if you reduce triglyceride, it can help reducing your atherosclerotic cardiovascular disease risk. That is the residual risk, what we usually comment.
Again, there is a study limitation, Shantanda, that control, if you remember, the control in the study was the oil, no? So
yes,
they did that actually.
Yes, the source of omega-3 fatty acid is very important. Source of omega-3 fatty acid.
I'm not talking about the source. I'm saying in the study where they use control, the placebo group, they received that oil, which actually increased the LDL. So,
yes.
So the control or the placebo in that particular trial was not an ideal one.
So
Exactly.
triglycerides only will be addressed when there is the threat for the acute pancreatitis.
Yes.
That means it is very high.
Till now, it should be there.
Till now, yes, more or less so.
Otherwise, we will not actually target the triglyceride. We always target the LDL cholesterol. And
also
the use of the fish oil, that will be effective in reducing the triglyceride and also some mild increase of the HDL cholesterol. But it is actually the dose of 4 grams per day, and it is very expensive. And also the smell cannot be tolerated by the subject. So the fish oil has not been so much of use or importance in the treatment of the triglyceride till date.
And also, sir, the omega-3 fatty acid that is available in the Indian market, we don't have the pentanyl ether. So that's a specific composition that has been actually tried and that has yielded the result. And that also, there is some limitation in the study because the placebo group was actually not a perfect placebo. So the placebo group actually received something which actually had an increased risk of cardiovascular disease. So there is some limitation till we can clearly advocate the use of omega-3 for cardiac benefit. It definitely lowers the triglyceride, but whether that really translates into cardiac benefit is something we are yet to know.
We need to wait for the ongoing other studies with omega-3 fatty acid.
Right.
What you have mentioned is about reduced heat trial.
Reduce it, yes.
Above all, it is very expensive. So we cannot think about the omega-3 fatty acid or fish oil at the present scenario. Now, about the use of the statin on the onset of the chronic kidney disease, say at the stage of 3 or 3B or stage 4, then how can you actually approach for the statin therapy in this particular subjects, diabetes or without diabetes?
I think,
Sir, in this particular case of chronic kidney disease with reduced EGFR, the dose reduction is not necessary in case of atorvastatin. We can give as per our requirement.
Actually,
Sir, may I audible?
statins, hydrophilic and lipophilic statins. In atorvastatin is a lipophilic statin, and rosuvastatin is a hydrophilic statin. That's why sometimes we preferred lipophilic statin in patients with chronic kidney disease, and that's why sometimes we prefer atorvastatin over rosuvastatin. And usually in stage 3, 4 or advanced CKD, I do not prescribe more than 10 milligram of atorvastatin.
because
And
there
for-
is the risk of the muscle injury, and usually
Then
the
risk is there.
CKD subjects are actually sometimes are cachectic, so they have the less muscle mass and they have the more water mass. So we cannot assess practically on the weight basis what will be the dose of the statin, and so we have been using the lipidophilic statin like that of atorvastatin at the mild to moderate intensity therapy. And
And
with the
in-
advancement, yes, and with the
And-
advancement of CKD, when the subject reaches the end-stage renal disease or the subject is
Or on
some form of
dialysis.
hemodialysis, we practically avoid the statin in this situation. And actually, though there is the increased risk of the cardiovascular injury, but we have been using the other agents which actually reduce the LDL cholesterol level at this subject, because the subject, the lifespan has been already been limited, and the statin injury has been more noted in the advanced stage of the or the end stage of the renal disease, or the subject is on hemodialysis. Now,
Yes.
the statin therapy in heart failure. What will be your approach for the subjects of you initiate or the continuous statin therapy in heart failure subject? Any one of you?
Sir, heart failure is a state where we usually calculate the AST will be higher in patients of heart failure. So our target is to start with moderate intensity statin, and as in with heart failure, if there is association of any documented coronary artery disease, as you have mentioned earlier, the first 6 months after the we may use high intensity statin in case of established CAD, and any patient with heart failure, usually we use moderate intensity statin, and depending on the LDL cholesterol level.
Actually, in heart failure, we have to use as low as possible the dose of the statin. And in the advanced stage of heart failure, that is NYHA class 4, we have to avoid the statin because that will not be seen beneficial in this subject. Now, with all this, I think that considering the use of the statin in diabetic population, in non-diabetic population, and also in the subjects with the ASCVD, and also the subjects having the other evidence of the ASCVD, of the peripheral arterial disease, we have to use the moderate to high intensity statin therapy. And in the say the subject of the past cerebral stroke, then what will be your approach for your statin therapy?
Means,
The subject has past cerebral stroke.
This ischemic cerebrovascular accidents.
Ischemic, yes. Not the hemorrhagic.
In non-hemorrhagic ischemic stroke patients, again, the recommendation is to give moderate or high intensity statin. In my practice, I do not get the patients who are immediately having acute ischemic stroke or follow-up, but those who are having a history of cerebrovascular accident, non-hemorrhagic, I usually, even if he or she may not be diabetic at that particular point, maybe having some prediabetes or some mild dysglycemia, but I feel the continuing statin in this patient who is having a history of non-hemorrhagic or ischemic CVA, we should continue statin in maximum tolerated dose what has been prescribed.
I would like to take this question because my thesis was in MD was this ischemic stroke and its evaluation of statin. So what is the recommendation is that patients with ischemic CVA should ideally, this should be treated as a ASCVD. So they should receive a high intensity statin. Now, there is evidence, there are about 2 to 3 studies which have shown that those patients who were earlier on a statin and due to some reason they were discontinued the statin post, they have actually undergone ischemic CVA. So these patients actually had a higher mortality in the short term. So in the next 3 months, this patient, those who had stopped, had a statistically significant higher mortality. Most of this data is actually based on atorvastatin because it is more older and more studied. And regarding if the patient has any other comorbidities, so that needs to be taken care of accordingly. But if the patient has suffered from ischemic CVA, we should start the patient on a high intensity statin. If the patient is within 75 years, the recommendation is usually in Western countries, because they tolerate the statin well, is to start a statin of 80 milligram, and maybe either you can continue or you can taper it down. So India,
and continue.
Yes, and continue, or you can taper it down if the patient is not tolerating it. But if the patient is already on a statin, that must be continued.
Exactly.
If the patient is having ischemic CVA, because they believe there's a hypothesis that probably because of the pleiotropic effects of the statin, they might be additionally giving some benefit, which is lost when there is oxidative stress in those patients who undergo a ischemic CVA. So because of that, stopping of statin may actually increase the mortality rate.
May actually harm, actually.
Yes.
Actually, in the ischemic cerebral stroke, we have to follow the same protocols like that of the ASCVD.
Acute coronary
Yes,
syndrome.
yes.
To target to reduce the carotid intima media thickness. And in Jupiter study, it has been clearly shown that rosuvastatin will reduce the carotid intima media thickness significantly. And I think that maybe the subsequent ischemic cerebral stroke can be prevented with that of the use of the rosuvastatin. And I think that today practically we have covered all the aspects of the statin therapy in the different scenarios, and the combination of statin and aspirin, statin, clopidogrel, or the use of the statin, aspirin, or clopidogrel, or the ticagrelor or the prasugrel, we cannot discuss in this short span. So I think that we may end the session here, and I think that there may be some questions in the chat box, and I request anyone of the Alkem who have been attending the session to see the chat box if there are any questions or not.
Sir, no question is there.
No question is there.
I have one question that, sir, how low of LDL we should consider safe? Means sometimes we have a concern that if we reduce LDL to below 40, that can lead to some untoward events. Some evidence is also there. So means how low LDL is considered, can be considered safe? Means in our practice, should we low it if below 40? Is there any concern actually?
Actually, you see that if the subject has the several infractions, myocardial infarction in the past, or the subject has been practically angioplasty in the with the stent in 2 or 3 vessels, and to prevent the stent thrombosis, or if the subject has the recurrent thrombotic events, then
Very
actually
high risk, very high risk.
is between 30 to 40, and that has shown that that will reduce the risk of the further events at least, and can increase the lifespan by 2 to 5 years in the different drugs. So at this high risk subject, very high risk subject, you can go for the target till to 30 milligram of LDL cholesterol, because LDL cholesterol actually not supplying the cholesterol to the organs which have been requiring the cholesterol for the synthesis of the steroid hormones, or for the synthesis of the cells like that, because that has been actually now found that has been practically supplied by the HDL cholesterol. So LDL cholesterol practically nothing role, but below 30 there is no study. So up to 30, with the at the very high risk subject, you can attain to that level, but it is very difficult to attain that level with the even with the high intensity statin therapy or the tolerated dose. So maximum tolerated dose with the target you can achieve, that will be enough for the prevention of the further atherosclerotic cardiovascular events or the recurrence of thrombosis. And the other agents like the antithrombotic agents can be used. And rivaroxaban has some small studies, but larger studies will be needed, because when you have been also using the antithrombotic or other high potent antiplatelet agents, and as the subject actually aging one, you also increase the risk of bleeding. So you have to balance between all this, and then you have to actually use your clinical judgment to use the different combinations with the statin and other antiplatelet and antithrombotic agents.
Shantan, the one more point I would like to add. There are some studies which has shown that in those patients who have a LDL receptor gain mutation, so in them actually LDL is very low, even less than 10.
Below 30.
Below 30, yes. So even less than 10, it has been shown. So those studies actually showed that these patients actually didn't have any other problems happening because of this particular, these are very rare mutations, but these patients, they have been followed up, and it has been seen that there is no additional problem happening because of LDL being this low.
Actually, the concern is probably not for adults, but what you know that
Children.
Pediatric dyslipidemia.
Yes.
That is a very neglected area also. In pediatric age group, the lowering LDL to a very low level like below 40 or below 30, we don't know whether have some effect on, you may say, the brain development or cognition.
And that is why I talked about the gain in mutation, because these patients have this problem from the very start. So they have been followed up, and till whatever data I studied past few years back, so they showed that there is no problem in this adolescents or children.
Yes, that is
the time we were being followed up. So long-term data.
Known about the orbital hypoproteinemia, and that practically will not practically increase the any risk. But I think that in the pediatric age group, it is very difficult for the target treatment for the LDL cholesterol, and so the regular follow-up will be needed.
Very difficult to use statin below 10 years. It's not recommended also.
I have one question for Dr. Kundu and Dr. Shantanu Rai, please. So those patients who we see that we suspect that probably this patient, clinically we suspect that this patient might be having a non-alcoholic steatohepatitis.
Yes,
and because
I was just going to ask that question.
So, and we know that this patient also have a microalbuminuria and other risk factors which puts them at a very high cardiovascular risk along with diabetes. So regarding the use of statins in this group, because we know that if we use a statin in an established case of NASH, then it is very safe. But to establish a definitive diagnosis of NASH, and also for medical legal purpose, we will need a liver biopsy, which is very difficult to convince the
Yes,
patient to
yes.
do it.
And
So
that too for serial biopsy. That
serial
too
biopsy.
difficult for serial
Yes,
biopsy.
because a serial biopsy we may not be able to detect
Yes,
because
yes.
it might be a focal issue. So what to do in those group of patients, when to start the statin and how to approach this particular case?
Sir,
Actually, more studies will be needed. I think that there are no clear-cut guidelines for that. And it is your clinical judgment that whether you have to initiate statin or not. Because in NASH, there are the different stages. There are first the steatosis, then steatohepatitis, then there are the fibrosis, and then ultimately non-alcoholic fatty liver disease. So there are the stages, and the different stages are the different behaviors and different clinical progression of the course, and you have to clinically judge the subject and then go for that. And also you go to a liver enzyme test serially after the initiation of statin, whether that has been practically the liver function has been improving or not, or been deteriorating or not, and then you have to judge your clinical judgment for the continuation of the statin therapy. I think that in this Sunday evening, we have been already chat for more than 1 hour, and practically that's very good evening, and I think that all of you enjoyed it, and I thanks the organizer for actually arranging such a very interesting virtual panel discussion, and thanks to all of the panelists for attending the session, and thanks to all the members of the ALCOM again. Thank you very much.
Thank you, sir. Thank you, Dr.
Okay,
Shantanu,
then
Dr.
we can now.
Gonapalli, and Dr. P.K. Kundu, sir. Thank you, sir.
Thank you. Thank you. Thanks to
yeah, thanks to all and good night.
Good night, sir.
good night. Good night.
Good night. Bye.
Good night. Bye bye.